Hi everyone. We're glad to have a terrific group today for our Google Hangout from Evidence-Based Mental Health. We're discussing today interventions to prevent self-harm. What does the evidence say? And our presentation and discussion today will be led by Keith Hawton, consultant psychiatrist, professor at Oxford University. Who is the author of a recently published Cochrane review on subject, and will be joined by he and several colleagues, Rory O'Connor in Glasgow, Annette Erlangsen, Katrina, Witt, and Ellen Townsend. Hopefully will join us soon too. Keith is going to start the presentation this morning, and why don't you go ahead and introduce your talk, if we can bring it up here.
Okay, thank you. Thanks very much, Michael. What I'd like to do is just say a little bit about what self-harm is, why it's important, and why it's important to provide, to find interventions that might help people who self-harm, and then to talk a little bit about the review, well, reviews, actually multiple reviews, before we go on to discuss these. So, first of all, what do we mean by self-harm? Well, we use the approach that's really very much in vogue on this side of the Atlantic, and that is to use an all-embracing definition, intentional, obviously non-fatal, intentional self-poisoning or self-injury, irrespective of the degree of suicidal intent. In other words, irrespective of whether a person wanted to die or showed any sort of suicidal intention, or the nature of other motives that might have been involved, such as showing distress to other people, wanting to escape from a situation, and so on. Now, why is self-harm important? Well, first of all, it's very commonly repeated. In the UK, at least, we know that over 20% of patients who present with an episode of self-harm to hospital will repeat and present to the same hospital within a year. Now, that's clearly an underestimation of the full rate of repetition, because people might go elsewhere or repeat in the community and not go to hospital. Now, very importantly, we know that about 1 in 25 will die by suicide in the year of self-harm, after self-harm. And that's something like 50 or over 50 times the general population risk of suicide. Looking at it the other way around, of people who die by suicide, we know that over half have a history of non-fatal self-harm. And indeed, data from the UK suggests that about 15% of people who die by suicide will have presented to a general hospital for self-harm in the year before their death. Other important aspects are that it's extremely common. In the UK, we estimate there are about 200,000 hospital presentations per year. Clearly represents major distress on the part of the individuals concerned. It presents major demands on general hospitals and on psychiatric staff, involving huge healthcare costs. But of course, there are major personal costs for the individual and costs to their family. So it's really important that we try to find effective treatments to reduce the risk of further self-harm, and also to reduce the emotional difficulties such as depression, anxiety, hopelessness, thoughts of suicide and further self-harm that the individuals might face. We know that self-harm often is precipitated by major life events. Mental health problems, particularly depression and anxiety, are common. Also alcohol misuse. And some individuals have personality difficulties that may make them particularly vulnerable to repeated self-harm. And we know there are certain psychological characteristics which increase vulnerability to self-harm. So because of all this, in the late 1990s, we conducted a Cochrane review which was published in the Cochrane Library in 1999. This included both psychosocial and pharmacological treatments for people of all ages. The inclusion criterion was that all individuals included in the studies, in the trials, should have engaged in self-harm shortly beforehand. So all of them had to have had a history of recent self-harm. Now, at that time, our review suggested there was little evidence of any effective interventions. However, we contributed an update of the review that we were working on to our National Institute for Clinical Excellence, as it was called then, in about 2010, and that was included in the NICE, as it's called, guidance on longer-term care for self-harm patients in 2011, when there was beginning to be emerging evidence that brief psychological therapy might be effective. So that brings us on to the current reviews. When we started to try and update the evidence, we found that there were a lot more trials than had been published when we were doing the previous updates. And as a result of this, we decided with Cochrane to split the review into 3 reviews. The first was a review of pharmacological interventions for adults, adult patients who self-harmed. That was published last year. We identified just 7 randomized controlled trials with no significant evidence for most of the physical interventions that were included, such as antidepressants, antipsychotics, lithium or omega-3 fatty acid supplements. But there was evidence in a very early trial of an old antipsychotic drug, fluphenthixol, that this might reduce repetition of self-harm in people with a history of multiple episodes. But that was a very old trial, hasn't been replicated. And then the second review, which was published earlier this year, was focused on interventions for children and adolescents who self-harm. This included 11 trials. Again, the results were really somewhat disappointing. The only really positive finding being a reduction in frequency of repetition of self-harm over time in a trial of dialectical behavior therapy, which I'll speak about more in a moment, which have been adapted for adolescents. So that brings us on to the third and really the main review, which has just been published in the Cochrane Library. This is focused on psychosocial interventions for adults who self-harm. We identified 55 trials that met our inclusion criteria, including over 17,500 participants. The largest group of trials, there are 18 trials altogether in this, was focused on cognitive behavioral-based psychotherapy compared to treatment as usual. In other words, the treatment that patients would normally have received. The cognitive behavioral based psychotherapy included both CBT and problem-solving type therapy. And we found in the meta-analysis that there was a significant reduction in the proportion of patients who reported self-harm after the end of therapy. So there were 18 studies altogether, and I'm just going to give you 1 or 2 examples of the outcomes. This was a repetition of self-harm 6 months after the end of therapy, when we had 11 trials of individual therapy. There was also 1 trial of group psychotherapy, which is included here. And you see across the individual psychotherapy trials, there was evidence of a significant effect in terms of the overall odds ratio and in terms of repetition of self-harm. no evidence of effect of the group psychotherapy intervention, but when we included that with the other trials, then there was an overall effect. And here we've included all the trials that had data on repetition of self-harm in terms of the evidence at the last follow-up. And you can see it's a similar picture, quite a lot of variation between the studies, but overall a significant benefit in terms of repetition of self-harm. We also found evidence of benefit of the brief psychological therapy compared with treatment as usual for some other outcomes, including depression, hopelessness, and suicidal ideation, or at least at one of the assessments for suicidal ideation. Now, just to give you an example, here are the depression scores, the findings for depression at final follow-up. I think there's about 13 trials where there were data from those individual for individual therapy, and the other one for group psychotherapy. And overall, you can see there was although the variation was quite considerable across the data, but overall there was seemed to be significant benefit for depressive symptoms in these individuals. There are also 3 trials of dialectical behavior therapy, which is an intensive and fairly lengthy intervention, usually for people who have a history of frequent repetition of self-harm and may be diagnosed with some sort of personality disorder. And while, as you can see from this slide, there were 3 trials included in the review of this kind, you can see that there was no overall benefit, appeared to be no overall benefit in terms of the proportion of patients repeating self-harm. There was an effect shown at the bottom of the slide in terms of the number of episodes of self-harm found after this intervention. There was also evidence from the review in terms of repetition of self-harm from 2 small trials of so-called group-based emotion regulation therapy. They were conducted by the same research group, and also from a single trial of mentalization. We found no evidence, however, of benefits for a range of other psychosocial interventions, for example, keeping in contact with patients by telephone or postcards, case management, there were 3 trials of that, provision of emergency cards to patients, but a lot of the other interventions had only been evaluated in single trials. So if we can turn the slide off. So in conclusion, I suppose the main finding of the review is that it would suggest that brief CBT-based psychological therapy may be beneficial for for adult patients who self-harm. We wouldn't suggest that this is suitable for all patients. I mean, an estimate that some of us have made is that around 30% of patients in this patient population may be suitable for this therapy. And we would also, the data would also suggest that group-based therapies along the DBT type line may help patients with a history of multiple episodes of self-harm reduce their frequency of self-harm. So I think those are the sort of main conclusions from the review.
Yeah, that's quite terrific, actually, and I think it's provocative results for those who are treating patients, of course. Rory, did you want to start? Did you have a comment that you wanted to start with?
I think it's great to see the Cochrane evidence being updated, and it's great news, obviously, that albeit that the evidence is still not where we would like it to be, that there's been an improvement certainly in the number of studies certainly being conducted, and we now have some evidence at least, or some confidence, that cognitive behavioural stroke problem-solving type interventions offer the most promise. I suppose my first question to you, Keith, is even having said that, you obviously, when you look at the quality ratings, the quality of the studies for CBT are still moderate. So I'm wondering, in your experience of reading through the sort of history of the studies and how we've moved forward, can you have any explanation of why we haven't got better quality of studies for CBT, which is a well-recognized, well-manualized treatment?
Well, I mean, I think there's been some improvement in the trials in this field, and Katrina Witt will, I'm sure, maybe be able to help me on this, but we've seen some increase certainly in the size of trials, which is obviously important, and in the way data have been collected, and probably to some extent in the way the interventions have been described. But there are some issues around that I'm sure we'll get into when we perhaps touch on treatment as usual as the comparison. I mean, I think and one of the issues, of course, that was raised by someone else was the Cochrane ratings of quality, and of course any psychosocial interventions are going to be at a disadvantage, say, compared with pharmacological interventions, because Cochrane places a lot of emphasis on blinding of participants and of therapists. I mean, you know, and that's clearly impossible, pretty well impossible in psychosocial trials. So I do feel that these sorts of interventions get a bit harsh treatment in terms of their quality, but nonetheless, you know, we have to accept that the quality often is less than might be desired.
Mm-hmm. That's really helpful. I'll sort of follow up on that. Is really looking then at the subgroups of. You've made the point. We think in an estimate that CBT may be effective in about 30% of patients. But what we don't really know enough about is, obviously, we know that men are more likely to kill themselves. But you weren't able to make any real conclusions about whether the treatments work differentially for men and women. So again, I think just really looking at your commentary on that, have there been more men included in studies in the last decade since you did the 1998 Cochrane?
I don't think so. I mean, it's still very much a female preponderance, and it's true, Kat, isn't it?
That's correct. Yeah, there hasn't been a significant increase in numbers of males who are included in these trials throughout time, and of course there hasn't to date been a trial that's looked at effects in males specifically, for example, even, whereas you do get a number of trials that have looked for effects specifically in females. So
I mean, one point worth making is that we tried to get gender specific outcome data, and well, we've actually found that very difficult for most of the trials and most of the interventions. We did have a certain amount of success that maybe Kat might want to comment on later. But, you know, there is this whole trials are designed, and the extent to which you know, people stratify trials in terms of gender as one of the obviously key characteristics, so that one can actually say something more specific about gender-specific effects, and indeed, you know, a bit more about who might benefit most. I mean, there may be other characteristics, obviously, that may be particularly important. Who you know, who's going to get most benefit, not just in terms of gender.
Isn't part of that due to I don't know, that the fact that we're not necessarily studying self-harm per se, but populations of people who might be at risk for it. So I know, you know, but for DBT, Marshall Linehan focused on borderline personality disorder, and at least here in the United States, nearly everyone diagnosed with it is female. So I wonder if the way we've sort of parsed people out has had an impact on whether or not men have been included in such studies.
Well, maybe I can comment on that first. I mean, I think that's dead right. That obviously, who are most likely to be female because they most often get the diagnosis, as Michael, as you were saying, of diagnosis of borderline personality disorder. And I think, I mean, that's absolutely true. And I suppose one of the points we really do need to make clear, particularly for people who aren't that familiar with this field, is that different types of interventions are going to be focused on different sorts of patients who self-harm. And so we're not talking about probably the exact same patients in each of the types of interventions. I mean, there's some gender specificity, obviously, and characteristic specificity in terms of, particular interventions. I don't know, Kat, do you want to say anything about that?
Yeah, I mean, I suppose the other point that comes to mind on this issue is the fact that in studies from the developed nations, a large proportion of the patients were identified following an episode of self-poisoning specifically, which again we know tends to be more prevalent in females as compared with males, which is again probably influencing the fact that we then pick up a greater proportion of females in these kinds of studies, because that was an inclusion criterion into the study.
One other just important point that arises from what Kat said then is that one of the good things we've seen is that while the trials are mostly Western type in Western type countries, that we are beginning to see trials now from Asia and other parts of the world, and that's certainly to be very much welcomed.
But just going back to the characteristics, I'm just wondering, can you say more about history of self-harm as a moderator of effectiveness in treatments? Because obviously we know from some of the brief intervention work, the postcard type studies, is they may be effective in a particular subgroup of females who are repeatedly self-harming. So have you any sense of whether the evidence base for CBT, for example, we've talked already about DBT, but for CBT, I mean, can we say that it's effective for that subgroup of people who are repeatedly self-harming?
No, I don't think we can say that. Partly because the trials haven't been stratified in a way that would allow one to examine those with, maybe a history of one episode or two episodes, those with a moderate number of episodes, and those with a large number of episodes. I mean, that hasn't been done. I mean, I think that, so I think the answer, you're absolutely right. We can't say that.
And I suppose one important consideration to bear in mind when we're discussing differential effectiveness in the context of the Cochrane review, either by gender or by people with a history of multiple episodes of self-harm, is, as Keith picked up on in his introduction, it was very much based on post hoc data that we were able to get from one author, but perhaps not another author, just because their data wasn't arranged in such a way to enable them to extract it differentially. So by definition, there are problems then with randomization, because you've broken it if you're looking at if you're looking at post hoc effects. So any of this is hypothesis generating only. We can't actually conclude that any intervention is more or less effective by gender or by repeater status as a consequence.
Although it's worth saying, I think, Kat, you agree that where we were able to look at gender-specific effects, that it appeared that the benefits were primarily in females.
Yes. Yeah.
So you would like to have more evidence, both with respect to gender, but also with respect to the cases that are more complex, with those that repeat several times.
Well, I mean, I think in terms of the future, I mean, we would strongly urge people designing trials in this field to stratify by gender and repetitions, history of repetition that would be really, really helpful. And that's hardly been done. There have been one or two trials where people have done that, but it's hardly been done. And I think that's one of the conclusions that we would have out of this work. There are quite a lot of others about the methodology of future trials in this field, in which that we're going to be working on, trying to put together those ideas to help trialists in the future.
Annette, you've looked at populations of people and outcomes for self-harm related to their receiving interventions or not from an epidemiologic perspective. And one of the things that I think is a tension here with the data and its quality is that really what you're trying to look at is whether or not a specific kind of therapy is helpful or not, rather than any therapy versus no therapy. And I think probably there's got to be a big ethical discussion around methodology if you're going to compare treatments for this kind of population, because I think most of us would assume that, or rather not be in equipoise about whether people should be in any kind of treatment or not if they've harmed themselves. And I think it makes it probably difficult to design studies that have the kind of quality I think that Cochrane would be interested in. But Annette, would you care to address that? Because I know you've looked at some populations.
Yeah, I mean,
it's kind of an open question, but I'll try. So I'd say firstly that we are very, very pleased to see this Cochrane review here, because it's of course an excellent effort and such a tremendous effort also. And especially since it has a very positive result this time. I can say that the studies we have been conducting in Denmark. In Denmark, we have some suicide prevention clinics who do give psychosocial therapy to people who either have had an episode of self-harm or severe suicidal ideation. But this effort was already implemented without the evidence of Cochrane. But since it's already existing, we can't really conduct an RCT on it. We'd love to have that level of evidence, of course, but it doesn't seem ethical since the treatment is already implemented nationwide to try and test it in an RCT. But we did test it in using observational data, and we found that it did have a preventive effect against repeat suicide or self-harm, and also against death by suicide. So that's an advantage we can say that observational data can offer if you have a large sample. Because that's one of the things we really want to address also with our treatment, that is that people have fatal outcomes, of course. And to do that in an RCT or even in a Cochrane review, that is not really feasible, I would say.
I see.
We did actually, I mean, I didn't mention this, we did look at suicide as an outcome where we could get the data. And as Annette said, I mean, the problem, of course, is power, and that fortunately suicide is a rare outcome. And in general, and in these trials, I mean, there were, for example, in the trials of brief psychological therapy, CBT-based therapy, there were, I think, 24 suicides, and 15 in the treatment as usual groups, and 9 in the the experimental treatment group, which clearly wasn't a significant difference, although it was encouraging, it was going in the right direction. The other thing to say is that one thing that interested us when we saw Annette's paper was that the sort of, while we don't know much about the content of your intervention, I think it's, or the interventions provided in Denmark, I think it's fair to say, the effect size that you found in your naturalistic study was very similar to what we found in the Cochrane review, which I thought was interesting in terms of self-harm.
Yeah. I can say on my behalf that we're very happy for the Cochrane review now, because we sort of feel that supports the effort that we are doing. Now we can say, well, it does seem to work, because we would of course consider the treatment we give as fitting in under the criteria of CBT. It's true that the thing we are offering in the clinics is very expert driven, we would like to say, because the clinicians that work there, the only thing they do is see people who are at risk of suicide. So they've developed a lot of expertise in how to address it using different types of psychosocial therapeutic tools, one could say. But in terms of this, I was just curious, Keith, when you when Rory touched upon the different studies that you included, did you have any kind of restrictions with respect to the intensity of the interventions in these first meta-analysis you did where you had a positive effect? Was this...
What, in terms of the... No, we didn't have any... I'm sorry. We didn't have any restrictions, but I think what was for all the trials of the CBT-based psychological therapy, the intervention was generally brief. In none of them were virtually no patients received more than 10 sessions. In some of them, it was a lot briefer than that. Most of them, it was a lot. Considerably briefer. So we are talking about lengthy psychotherapy. For most, I suppose on average, we would be talking somewhere between 4 to 6 sessions of psychotherapy. Yeah.
I'm just interested. Oh, sorry. Go on ahead, Kat.
Sorry, but again, as Keith said, that represents a theoretical maximum, because one of the limitations you get with these trials in comparison with, say, for example, more comprehensive trials of CBT therapy for depression in children and adolescents is none of the studies really measured fidelity or adherence to the manualised treatment. They didn't generally record number of sessions attended. Some of them did, but they didn't generally record how many sessions were attended for each participant, etc. So again, that's somewhere to develop into the future, that we do need better measures of fidelity for these trials as well, so we can actually find out what dose participants are actually receiving of the experimental intervention.
No, I think that's really helpful. I'm just going to make the broader point, just based on something that, well, Keith said in response to Annette about the effect sizes being similar in the naturalistic versus in a Cochrane. Because one of my concerns, going back to an earlier point, I think Michael might have made about, and Keith made about how Cochrane assess quality and the requirements. And with this patient population, that we have to be pragmatic. And that my concern was that is the evidence that we're getting from Cochrane so skewed because the people in those studies are not representative of the target population. So it's reassuring to note that there seems to be some evidence, certainly, that of this common effect size. So hopefully we have some evidence not just for efficacy in terms of the Cochrane, but for effectiveness if we take it in the context of Annette's work. So I think that is really positive and something we certainly didn't know in 1998 when you published the last Cochrane.
Yeah. Yeah, no, I'd entirely agree. I think having evidence from randomized control studies, meta-analyses of studies, and from naturalistic studies is really a powerful approach. I mean, we've all been so tied into the RCT, as being the gold standard. But when you can bring both studies, naturalistic studies, real setting studies, so to speak, together with RCT evidence, and you get a similarity in findings, I think that's very powerful, particularly for people designing clinical services.
Yeah. In terms of that, I was curious, Keith, because you have this very positive finding, we can say, for CBT. So does that make you confident? Is this now what we can implement as standard treatment? Do we need any more trials? Well,
I think we do. I mean, I think going back to what we were saying earlier, is one of the problems one of the things we don't know is really for whom it is effective. I mean, this operates at two levels. One is the people who get into trials, but then there's the whole thing about gender effect, gender differences, and a history of self-harm, and probably other characteristics of people that may be particularly important in terms of identifying those for whom such a therapy is going to be effective. So I still think we're quite a way off. I don't think we should be pessimistic, because I think we've got at least a bit of positive finding to hang clinical services on. And I do feel there's enough strength in the findings now to be saying that this sort of psychological therapy should be available to self-harm services so that they can help patients receive it. But I think we've still got a lot more information that could help sharpen up the evidence and you know, identify people who are going to get most benefit.
I think just in addition to that, I think the other issue is, in addition to, you have some idea about dose broadly because of the obviously average is 4 to 6 sessions, but we've no idea, or do we, about what components of the therapy are effective in terms of mechanisms of change. We don't know enough about that. I think there's so much to be done, but at least we can start from a place which is saying this sort of psychological treatment is the optimal one to select at this stage. Certainly, we can say that.
Ellen, you're going to say something?
Can I come in there? Can you hear me now?
Yeah.
Yeah.
Yes.
Okay. I think Rory's making a really important point, but one of the things that we still face with these trials is that most of them are still really tiny. And the last time I looked at it, you know, the average, and this was a while ago, participants recruited was something like 81. And Keith, do you remember the methodological paper we wrote a long time ago where we estimated the minimum number of participants you'd need for one of these trials if you are expecting a 40% repetition rate would be something like 91, but if you went for a more realistic repetition rate over a period of year, which is about 20%, you'd be looking at over 6,000 people randomized in a trial. So if you're looking at moderating and mediating effects, you're going to need really large trials. The other point I wanted to make, which I think is really important here, is how we implement this evidence into practice. Because I think there's a huge gap between the work that we're producing showing positive effects and actually implementing that in care pathways. Currently, services for self-harm don't really fit within a psychiatric care pathway in the UK. And I think we need some fundamental work about how we can organise those services for people presenting to hospital for self-harm.
I think that's a really important point. I mean, one of the things we know, and obviously the situation may be different in the United States, is that an awful lot of these patients do not receive any aftercare. I mean, of any substance.
Well,
sorry?
Only 50% are even assessed presenting to hospital, right? So.
Yeah, although that is improving, I think, now that we're getting 24-hour services. I mean, from our multi-centre study of self-harm in England, it looks as though there's beginning to be an improvement from other data we've got. But yes, I mean, you're quite right. Just at the fundamental level of whether people get assessed, let alone get into therapy, we're still way off things being perfect. The other issue, and I know Annette's raised this with me before, is this whole question in terms of the review of what we're comparing the psychological therapy with, because we talk about treatment as usual, treatment that people will usually receive, but that it by itself raises lots of issues, not least about what will be treatment as usual in one centre as opposed to another centre within a particular country, and particularly between countries. And there's going to be huge differences, which, in terms of a trial of this kind, is a review of this kind, is really a major limitation. I don't know, Kat, whether you want to comment on this, because I'm trying to get a bit more of a handle on
Yeah.
Curious on also that the treatment as usual, particularly in some of the developing countries that actually contributed positively to the Cochrane review, if they might sort of lead the result a bit in that direction. As I understood, you didn't do any kind of adjusting or checking for different, say, whether the findings were supported in developed countries only, for instance, or so. How happy are you with the results in that respect?
I think there's just too few trials from lower and middle income countries, I use the correct terminology these days, to actually say anything about that. I think that's right.
And generally, the studies that were conducted in lower to middle income countries were not of CBT or DBT or any of those more complex psychological interventions that would enable us to pass out effects. They generally tended to be lower intensity interventions such as giving information, advice, support, psychosocial therapy by telephone, etc., which didn't allow us to make direct comparisons with other like-for-like treatments in developed nations. So that's one of the problems that emerges from the review, that we don't really tend to have evidence for the more complex multi-component types of trials in these types of settings. And of course the other thing comes back to what Rory was saying a little bit ago about that a lot of these interventions are complex and multi-component, and we don't know exactly which component, if any, is responsible for carrying the treatment effect, or is it the package as a whole? There's been some development in this in the field of DBT. So Marsha Linehan is looking to do some head-to-head trials of DBT where she, for example, drops out the individual psychotherapy component in one arm of the trial and drops out the group-based psychotherapy from another arm of the trial and compares that to DBT as per the manual. And I do think we probably need to start heading down the line of more head-to-head comparisons too, that do that pass out the effects of the components of these interventions, which will also help control for some of the effects of TAU, because we'll be less reliant on that as a concept, potentially.
No, I think that's a great point. If I just could come in there and just add that, and relating to what I think was Ellen made about just understanding more, is that what we should have is, as a rule, in all of our trials, we should have a process evaluation embedded. And I think other fields of psychological science are much, and psychosocial science are much better at doing that. So I think in terms of best practice, we certainly should have a process evaluation, which would certainly tap in a bit to when interventions do work. We have some idea, a bit of information about why they might work, but crucially, and often is the case in our field, when they don't work, we have a better idea of why they don't work. And then the second point, which relates to Ellen's, again, talking about the care pathways and making sure we have some evidence that these treatments are effective, but people who need them don't get them. And again, our knowledge of implementation science, what are the barriers to treatment, why is it they aren't available? We know there are resources issues, but there are lots of other issues out there. So again, two urges or two calls for me is process evaluation and more implementation science on top of, but guided by the Cochrane review, which says CBT type interventions offer the most promise.
Yeah. Do you think that the Cochrane review will help the implementation process of psychosocial therapy in the UK?
Well, I think it will. When I did my introduction, I was talking about the NICE guidance, which is obviously very powerful in the UK in terms of providing guidance for clinical services. And I think with this strengthened evidence, and the NICE guidance has been now being updated, fairly regularly, that this will strengthen the guidance that NICE will provide. So at least at that level. The problem is when you get down to individual delivery systems, hospitals, and so on, how much people will really take on board. And we're not in the position, in this country at least, where an official body like NICE recommends a psychological therapy. We're not in the same position as when they recommend a drug therapy, or say you shouldn't use this drug for condition X, but you can use this drug, which is more or less absolute. But for psychological therapies and psychosocial interventions, it has much less clout in terms of the obligation for service providers to actually do what the evidence suggests. And I have to say that's one of the huge frustrations that many of us had for many, many years, that we can produce evidence or bring together evidence, such as through a review of this kind, but that in terms of what actually happens on the ground, it is still very difficult, and it's because it's a very slow process, we know, to make such changes. But I hope those of you certainly from the UK will probably have had, having the same experience in terms of that fact. So, yeah, I would say, there's stronger evidence now to influence the care pathway, but the providers and the purchasers of care, the system we have in the UK, where we have, people who purchase the care for the NHS, really need to be convinced and take it on board.
Just on the nice guidelines.
Sorry, Helen, you're going to say something?
Okay, do you see any other things that one could bring forward as arguments that would help convince policy?
I think there is, and one of the things we're working on is the healthcare costs of self-harm. I talked about the numbers of self-harm episodes. I mean, the estimate of 200,000 presentations per year. We're in the middle of trying to assess what the costs of that are to the healthcare system. I mean, that's just focusing on, obviously, part of the cost is the cost for families and the cost for individuals. But just in terms of healthcare costs, I think when one starts to do those sums and identify, how much this, and then, after all, both sides of the Atlantic, money talks, and start to provide that evidence, and particularly if we can start to also look at offsetting of costs from what evidence we do have, say, about the benefits of having a psychosocial assessment as well as having a psychological intervention, then I think we can start to maybe talk the talk, which people who make healthcare provision decisions will really start to understand, because the money's going to be involved, and substantial amounts of money.
Yeah, I absolutely agree, and I'd add to the point that Rory was saying before about what should these trials report down the track. He mentioned, for example, there should be a process evaluation so we can identify for what groups these might be successful treatments. He mentioned the implementation science so we can understand a little bit better about who is being involved in trials of this sort. I'd add a third, that we do actually need cost effectiveness analyses too, so that we can make the business case to purchasers of healthcare costs around the world.
Can I just add to that as well? Two things. One is, and I can't remember who asked the question about, are you more optimistic in the UK context and timing? Well, just at the minute, NICE are reviewing, those of us who are involved in the development of the long-term guidance in 2011, the surveillance is ongoing at the minute for more up-to-date studies. So that's good news in terms of timing of the publication of the most recent report. But the second one, you just beat me to the point, Kat, about the health economics, and it's such a straightforward thing now for us. There's established, David McDade and others who've been working in this area specifically in health economics, in suicide and self-harm. There are now well-established protocols to assess what we know about both the indirect and the direct costs of self-harm, and it's so vital.
I'm pleased to say Dave's helping us with our health and care economics.
Well, you just finished. We
do still have a significant problem in the structuring of services. In the UK, to access services, you have to have a diagnosable mental health condition to access the higher tier care. And given that these behaviours aren't currently they're under consideration as mental health issues. So it's not just about implementation science. It's about really fundamentally restructuring the way our services are delivered, and to take the focus away from diagnosable mental health problems.
Well, can I give one example from Scotland? Is that Scotland has adopted this approach now of trying to look at distress as opposed to a psychiatric diagnosis, and recognising the point you've just made, Ellen, that if it's diagnosis is the only way into treatment, that's problematic for many of the people. I know lots of people from Keith's work. Lots of people will have a mental disorder at the time of presentation, but lots don't. And I think what we're trying to do is recognise is that the distress, which is problematic, and then hopefully develop interventions and care pathways based on distress rather than based on a diagnosis.
I think it's really important for young people, and I think the evidence for the adult psychosocial therapy has really strengthened. But when you consider the additional evidence. So from the first review in 1998, we had six randomized controlled trials for young people. There have been 5 more. We still have a very, very limited evidence-based people.
Yeah, I must say, I mean, that is is really a surprise, because given the size of the problem in adolescence, and there's a huge amount in the media about the size of the problem of self-harm in adolescence, the amount of attention to trying to identify effective interventions has been really extraordinarily low, and which is a great surprise. I know there are obviously particular difficulties about doing intervention studies in adolescents, particularly those of younger age, in terms of consent and parental consent and so on. And of course, in adolescence, you're dealing with a very changing situation in the individual over time, which can, make evaluation actually quite complex, I think, compared with adults. But nonetheless, I think it is, that review really highlighted the main finding. Really was the paucity of, of trials that have been done.
Yeah, I have a
anecdote.
question. Do you want to go ahead, Ellen?
Can I follow up just to say, I think people are applying for funding. They're trying to get trials funded to examine interventions for young people, but they're not being prioritised. So I think there's a real call, if I was going to get on a soapbox in a kind of political dimension, for commissioners to fund this kind of work. Sorry, Annette, sorry.
Some more ICT trials for children and youth, so that the next Cochrane review in 10 years from now will have happy findings to report also.
Hopefully it would be earlier than that. But
in terms of that, I have a question, because DBT, we touched upon it earlier, it has a huge interest, especially from clinicians. They're very interested in that type of therapy. And for instance, in Norway, they are doing a big effort right now in implementing DBT towards youth groups, at least. So based on your findings from the Cochrane review, there isn't so much to support DBT yet, but do you have any comments about this area?
Well, as you know, again, certainly the experience here, and I guess in other countries, is that people have been applying in clinical services DBT for adolescents, just focusing on adolescents at the moment, have been applying a form of DBT, of dialectical behaviour therapy, for adolescents in routine clinical services. That's been happening in our local child and adolescent mental health service in Oxford and in many other places, without evidence that it's beneficial for children and adolescents. Now, there is some, as I think I touched on, some evidence that, but there's only, we identified only 2 trials that, correct me if I'm wrong, Kat, I think it was 2, wasn't it?
Yeah, that's correct. One of which was actually not published in a peer-reviewed manner.
No, that's true. And there was some indication of benefits for repetition, frequency of repetition of self-harm in one of the trials.
That's correct, yeah.
Overall, no sound evidence. So it's an example where the clinical development, interestingly, has gone way faster than the research evidence, and that is an area where there really is a need to get sound evidence, because DBT, although for adolescents it's usually much less lengthy than in adults, I think generally 3 to 6 months, whereas for adults it's usually a year of therapy. Nonetheless, it involves very significant therapy costs, and turning the health economics argument the other way around, one would like to see a justification for those therapy costs being a bit, bit sounder.
And I think
what about efforts to do more primary prevention? Let's say, I know there have been efforts to teach, for instance, mindfulness-based meditation to adolescents, others, as a kind of primary prevention rather than targeting necessarily at-risk populations. Any comments about that? Because I think what Rory, I think your point, I think, which is very important, is that because of the risks of the behavior and both the cost of healthcare, lives, morbidity, that we really need to think about how to implement this and how to study it in a real world population and move beyond the clinical trial setting to a clinical practice setting. So, any comments about that?
Yeah, can I come in there? We recently did some focus group work with young people, asking them what they felt would be, useful in terms of interventions. And the clear message that they sent to us was, you're waiting way too long. You need to be getting into primary schools, building resilience, teaching coping skills, teaching about mental health issues. We're waiting too long. So I think that's a really important point.
But I think the concern or the risk is, I know there is like the SAILI study, multi-center study in Europe, offered some promise for certain types of basically psychoeducation being effective with some of the outcomes in terms of reducing suicidality. But my concern is in the school context, is we know over the history of intervening in schools is there have been some risky interventions which have had obviously negative effects. So our concern is, and my concern particularly when we're trying to argue, and I'm one of these people who argues for getting mental health on the curriculum more central, not peripheral, but we need to be so careful because in terms of resilience, Ellen mentioned resilience. I have no idea what resilience is, how you measure it, how you go about intervening, but people do and say, oh, here's resilience training. So that's my concern. Once again, we're going ahead of the evidence, going ahead of the data, without having any understanding of the risks.
And I think another issue when we're talking about the intervention side, so the more tertiary state intervention for children and adolescents, comes back to a point that Keith touched on a moment ago. A lot of the interventions, the effectiveness for children and adolescents has been inferred from the evidence from adults. So that goes back to the nub of the problem with DBT particularly. It's been inferred to be probably effective for children and adolescents, mainly based on the findings that we find in the adult studies. So again, it comes back to the fact that we do need studies of interventions that have been tailored from the ground up for children and adolescents rather than an adapted form of something that we think works for adults, so therefore should probably work for children and adolescents as well.
But maybe just to add one very quick point, sorry Keith, which is, I'm going back to Ellen's point to the funders. We need funders to invest in that early stage work. If we look at the MRC guidance on the development of complex interventions, we shouldn't be shortcutting the early phases. And when we're tailoring to a new population, we have to do that. And one last point is, in Scotland here, I'm actually about to sweat to death here because it's so warm in Scotland.
Lucky you.
How did that happen?
It's only the 1 week of my entire life.
Oh my God. Turn off the coal-fired furnaces. What were you going to say, Rory?
No, that was me. Sorry. Keith was about to come on. I think.
Yeah, I was just going to make a point. Sorry, it's a small but important point. I think about DBT is often delivered in a group setting, usually delivered partly in a group setting, as well as a certain amount of individual therapy. Now, there was some evidence within this review, I won't go into the details, but in children and adolescents, therapy provided within a group setting for youngsters who are self-harming can actually have some downsides. And certainly there was one trial from Australia of group psychotherapy for adolescents where the occurrence of a repetition of self-harm was higher in the group that received the group therapy than in the control group, which didn't. And of course, there's the whole issue about contagion and so on in adolescence, which has to be borne in mind when you're thinking about the design of therapies. It's probably less important in many adults who self-harm.
Absolutely, and coming into what we might want to add into trials in this area in the future is definitely looking at effects for contagion. For example, I really only know of the Signs of Self-Injury program in the US, which is a school-based psychoeducational type of intervention that it did look for signs of contagion in addition to signs of effectiveness. But most studies don't really look for, they're sort of blinded to the potential for contagion.
Well, we are coming to the end of our hour. We could have another one. We're not scheduled yet to do so. This has been a really remarkable discussion, and I wanted to thank our speakers and especially Keith Hawton, who's presented the data from this recent Cochrane review, Katrina, Witt, Annette, Erlangsen, Rory O'Connor, and Ellen Townsend, also to the editor of Evidence-Based Mental Health, Andrea Cipriani, who's been sitting in the background, and to our two terrific new digital communication assistants, Veronica Heaney and Roxanne Keenajad, who are in the background, have made this possible today. I wanted to thank everyone for joining. I think this was a terrific, lively discussion and ended up in a place that I hadn't quite anticipated before we started, but I think shows how important the topic is and how devoted the people who are working in this area are to helping the lives of the people that we study. So thank you very much, and we'll go offline. Thank you.
Thank you.